So I appreciate the opportunity to talk to the PBMI crowd. Just before I get started with my introduction and what I'll be talking about, just by a show of hands, how many of you in the room are consultants or broker consultants? It's pretty bright up here actually. Only a handful. All right, how many are payers, be it health plans, couple, employers, even more? How about any new entrant digital health companies? Probably the rest. All right, excellent. I like to know who I'm talking to, and I think my conclusion from my impromptu survey is talking to a pretty wide audience. So my name is Jesse Ruzicka, as Jonathan said. I am Senior Vice President Sales at Abarca Health, where I've been employed for greater than 3 years now. But I have 20 years in PBM. I actually started in 2004 for a very large PBM doing underwriting and analytics. Took a role in their financial space, client-facing, ultimately worked through the channels of account management into sales. When I left them in 2017, I went into consulting for 4 years in the PBM space, and in May of 2021 joined Abarca. And it is a refreshing organization relative to some of my past. So again, I appreciate the opportunity to talk to you today. I'm going to set up the expectations for what we're going to talk about. Before that, I want to mention a particular TED Talk and book I became familiar with as a result of being employed with Abarca. So anybody here heard of Simon Sinek and his Start With Why? Oh, even more hands for that one than some of the other groups. So I'm talking to a professional audience. So as a new employee, all Abarcans go through a Start With Why discovery, and I wasn't familiar with it prior to starting, and I'll hopefully connect all the dots for you. But in his book, Simon talks about kind of the golden circle, and most people, especially in sales or in their business, are talking about what they do and how they do it. And what he suggested was businesses are most successful and employees are most engaged when people talk about why they do something. And so as a new Abarcan, I went through my why discovery. So all employees, as part of their onboarding, get assigned a coach, and we do a little storytelling, a little role play exercise and an interview, and then your why is determined. And again, I hadn't heard of it before 3 years ago. So in case you didn't know, there are 9 whys if you believe in this model. And so that I get them right, I'm going to read them. They are simplify, challenge, trust, make sense, better way, contribute, right way, and clarity. And so going through this exercise, I learned that my why is clarity. And so what that means in plain English is I want to understand how I'm going to be measured. I want to understand my role. I want to understand what's required of me. And that's generally kind of how I approach things. If I'm in a meeting, I might bring sense to it and find that clarity. So maybe there are a few why-minded folks in the room who have a clarity. And with clarity in mind, I want to talk just for a second about what I hope to accomplish with my time with you. I also want to talk a little bit about what's your role. Again, I took an impromptu survey, and we're pretty varied. I think we all have a responsibility in the pharmacy landscape. And I want to use this time to lead a session and really challenge you to think about your role and how we can collectively transform healthcare, starting with prescriptions. So, with that said, I'm going to start first with Abarca's why. So Abarca Health is a full-service PBM. If you're not in the know, we are exhibiting, and I'd be happy to take conversations. I have a couple of teammates with me here. But Abarca believes that our purpose is to find a better way in healthcare, beginning with prescriptions, by creating a seamless and personalized experience. And that seamless and personalized means incorporating a modern and cloud-based technology platform which connects to the provider, connects to the pharmacies, and connects to the patients at a point when patients are most likely to be good consumers of their healthcare and of their dollars. And so today we deliver a prescription experience that actually changes these behaviors. It makes them more adherent, it makes them be good consumers with their dollars, and again, we're bringing that data connection together. So between my why of clarity and Abarca's why of a better way, I'm hoping that together in this room we can find that better way. So the way that I've set up my 30+ minutes with you is I'm going to take about half the time, maybe a little less, and kind of set up the landscape of 4 occurrences of current events in the pharmacy space right now that are occurring. I don't know that any of them are super novel. Experts in the room may already have opinions and experiences with them, but I hope I present them in a way that really challenge you to think a little bit differently. And then I'm going to take the back half of that same time together and start to represent some solutions that may be opportunities for all of us. So in the order that I have them in the slide, more than maybe their importance, the first one I want to talk about is the increasing attention of federal and state lawmakers. So I was in a meeting recently with a payer, and the payer said, oh, PBMs, you're like tobacco, from 30 years ago. You got the target of the government on your back. And I thought to myself, man, I've been doing this for 20 years, and my goal is truly to find a way to make patients healthier and get their medications when they need them, right? I don't want a target on my back. And so I kind of reflected on that for a minute, and it turned, right? The conversation turned into one, well, the industry may have a black eye right now. And the reality is we're going to talk a little bit about the FTC. There are headwinds right now that are impacting the larger 3 PBMs. There's no doubt about it. In fact, some of those headwinds may actually cause them to lose some market share. But some of these same things that are potentially being regulated, or some of these reasons why there's a target on the back of the PBMs, may actually become tailwinds for other PBMs. And I really want to kind of think about that framework because the market share is likely to change, and there's an opportunity for us in the room to do that. So we're at an inflection point. That's the reality. We have to find a better way to manage pharmacy benefits. We have to create transparency. We have to be able to evaluate the different vendors in the marketplace. And so consultants in the room should feel obligated to find a way to do those evaluations. The reality is there are PBMs out there who are transparent, who clearly communicate the value of what they're providing and the services they're providing. And again, I believe the consultants have that role. So the US government is taking action, right? I'll talk a little bit through a few examples, but currently there are 15 bipartisan bills that have been introduced to regulate PBMs. And these proposals are focusing on requiring PBMs to disclose their pricing practices, disclose their rebates, and question the spread pricing model. While the feds are doing their analysis and regulation, the states are doing something similar. Attorneys general in 39 of the 50 states have petitioned the federal Congress to put regulations in place for PBMs. And as of November 2023, all 50 states have regulations on PBMs. Some of those regulations could be simple, like registering with state agencies, but they also require transparency. Transparency of spread model and transparency of rebates as example. And I think the state's goals in these instances are to ensure that patients have access to affordable medications. And so that's what the states have been focusing on. In 2022, the IRA was passed. I will not stand here and pretend to be an expert on the IRA. I will point out for you a few things that I think are relevant to this conversation. The provisions within the IRA mostly focus around lowering drug costs, and only a handful have an impact on pharmacy benefit managers themselves. The IRA addresses CMS's rights to negotiate the price of drugs for Medicare Parts B and D. It's shifting more risk and more cost, therefore, on the Medicare plans. It's easing the responsibility of the financials on the patient by creating pay over time and or putting in maximum out-of-pocket examples or out-of-pocket co-insurances or co-payments. It's also closed the donut hole. So a lot of you are familiar with that from many years of trying to create plan designs and how to navigate and consult around that. So it's been in existence for a period of time now. We have seen some early results. Examples include the impact on insulin copays, the impact on out-of-pocket, and even some patient pay requirements. Regarding the FTC, this is a little bit more current, but still at least a couple years old from where it started. Current events, July of 2024, less than 6 weeks ago, there was a committee meeting where CVS, ESI, and Optum were called into Congress to testify before our government. And I want to read a couple things that came out of this hearing so I don't get it wrong. All 3 executives testified that their PBMs do not steer patients to PBM-owned pharmacies, meaning they are not requiring their patients or providing financial incentives for patients to purchase medications from PBM-owned pharmacies. We know in the room that Express Scripts is the largest mail order. We know that CVS is the largest retail pharmacy. And so those statements were taken back because on August 28th, the U.S. House Committee on Oversight and Accountability issued letters to the 3 of them simply stating you have false testimony on those words. And so the letter gives them the opportunity to correct the congressional record or face penalties and fines. The reality is the reality is the FTC is continuing to investigate. The FTC report calls for increased scrutiny and potential reforms in the PBM industry to promote fair competition enhance transparency, and ultimately improve access to these affordable medications for consumers. And the FTC report has 6 main themes. And I'll go through them quickly, but I think they're relevant to the discussion. 1, market power and competition. So no surprise, the PBM, the report highlights the concerns about the significant purchasing power and market power held by the PBMs. Their concern is the lack of competition. Their concern is about the impact on the pharmaceutical supply chain. The report also addresses pricing practices. It was determined that the PBM's negotiation strategies and rebate systems can create complexities that are not beneficial to consumers. I think a lot of you in the room have familiarity with this. And then ultimately it could report to higher drug costs. A third focus of the FTC report was the lack of transparency in PBM operations. It calls for a disclosure of pricing, rebates, and the financial relationships within the supply chain. One of them that's a bit concerning, I'll address it a little bit more further in a few minutes, is the impact it's having on pharmacies. There are concerns about the rebates, the reimbursement rates from the network, and the challenges that are faced by the smaller pharmacies competing with the larger pharmacies. And so we have to talk a little bit more about the role of the pharmacist in the field. Of course, you can't expect a government regulatory agency to come back and say we need less government, so they're recommending more oversight and more regulation as part of this report. The final portion of the report that I think is relevant is the impact on the consumer. It advocates for policies that prioritize patient welfare and affordability, and so we'll see what comes of that over time. So overall, the regulatory landscapes for PBMs, it's evolving. A lot of discussions on how best to ensure they operate fairly and transparently while promoting access and medications for their patients. There's one more area that didn't quite fall into this one, but I think it's relevant. The lawsuit against Johnson & Johnson against its health plan fiduciaries actually sent shockwaves through the industry. This was several months ago. By now, you've all likely read about it. The lawsuit alleged that the company breached its fiduciary responsibilities under ERISA. Interestingly, within 1 month after that, Wells Fargo was sued for similar reasons. The lawsuit also alleged the breaching of fiduciary responsibilities, but it also delved into excessive fees. It was disclosed that in 2019, Wells Fargo paid $9 million to their PBM, and in 2022, they paid $25 million. So their concern, the lawsuit's concern, is lack of oversight and conflicts of interest. Interestingly, both lawsuits, J&J and Wells Fargo, used the same law firm, are suing the same PBM, and the same benefit consultant was advising the large employers. So payers and consultants, I said at the start of this, I might challenge you, hopefully get you to think a little bit differently. What is your role? Are you doing what's in best interest of the plan? Are you driving to the lowest net cost? And are you accepting PBM dollars as part of your compensation? And so why does it matter? The reality is government influence is mandating change. We put ourselves in this position. Payers, pharma manufacturers, PBMs, and consultants ultimately need to adapt to these changes. Payers are demanding visibility, so we should expect to see more reporting, more ROI, more visibility to how the dollars are made. Now, I want to be clear. There are PBMs in existence today whose pricing model clearly allows payers to understand the value they are receiving for the services they are receiving. And this trend will continue. More transparency, more disclosures, more competition in the marketplace will cause a shift in the PBM market share. And finally, employers are being held accountable. So if you're in a position where you're having to make these decisions, make sure you're fully familiar with the resources made available and that you're being good stewards. Next on the list, I have approvals of ultra-high cost drugs. In reality, this is probably one that requires the least explanation from me because it's something that payers have been struggling with for a while. So I'll offer a few statistics and a couple pieces of background. In 2023, the FDA approved 55 novel drugs. So a novel drug is one that is assisting or hopefully mitigating or maybe even solving or curing a new disease state that does not have any drugs. Okay, so 55 novel drugs. 28 of those received an orphan drug designation. So again, that means a very limited amount of population on these drugs. Why does it matter here? Because those drugs are expensive. 3 of those 28 drugs have costs greater than $1 million, and the highest is $4 million per year. To be fair, in my research, the $4 million is a one-time event, but if you're a small employer in the room, think about that impact on your insurance premiums, and if you're a self-funded payer, $4 million for one patient is a lot to handle. Last year, there were 5 biosimilar drugs approved. We've been waiting for years. I've been in this room listening to speakers talk about the role that biosimilars will have. Have they proven to be the answer? Probably unknown, possibly no. New market entrants, direct-to-consumer advertising, and expanded use of existing products in the biosimilars are pushing the utilization up, and they're keeping that overall trend positive. In 2023, several dozen drugs received approvals for additional indications of new uses. So again, you're seeing a drug come to market for an approved disease state. Over the course of time, more are covered. This is increasing our utilization and our costs. There are over 700 investigational drugs for oncology. So the science is amazing. People can be healthier, live longer. In fact, in many cases, cancer is becoming a chronic condition. The reality is someone has to pay for that. On average, the annual cost of new oncology products exceeds $250,000 a year. And I said there are 700 drugs in the pipeline. The elephant in the room are the GLP-1s. I happen to know there are a couple people here who are talking about the value of their GLP medications. Greater than 100 Americans are classified obese, and 11% of Americans have diabetes. The jury is out on the long-term effects of these drugs, but the reality is we're seeing in the use of them that they're working, but they're incredibly expensive. Right now, 2024 global revenue projections for the GLP-1 category is $47 billion in spend. By 2032, roughly 7+ years from now, it's expected to be 10 times that number, $470 billion on GLPs alone. JP Morgan Research forecasts that patients on GLPs could exceed 30 million Americans by the end of the decade. So as you're thinking about your role, how can we use these drugs in the best interest of our patients, making them healthier and still managing those costs? So let's talk about the impact that these high-cost drugs are having. And again, as I stated, it's probably the area that needs the least discussion, but the increased financial burden, it's often greater than $100,000 per year and places a financial burden on the patient and on the payer. Insurers are facing higher costs to cover, which is increasing premiums, which is increasing out-of-pocket, which is impacting adherence. And so consumers are having to decide how they fit these expensive drugs into their budget. And so what are payers doing? How are they reacting? Some of these are self-evident, right? There's changes in benefit design. People are being asked to pay more. People are having, again, higher co-payments or higher co-insurances, or maybe they're being channeled to a specialty tier or maybe even a specialty provider. We're seeing more prior authorization and drug utilization management. This is a common strategy. There's a couple vendors in the room here who specialize in that area. This is one way you can control who's using these drugs. One thing I think can come from this that's a positive, we're going to see hopefully more of this, is the negotiation of value-based pricing. I think most payers in the room would say, well, I'm willing to pay for these drugs provided someone can prove to me that they're working. And so there's a greater emphasis on negotiating prices for these costs as part of a value-based price model. Payers want to seek reimbursement for clinical outcomes and not just volume of drugs dispensed. We're seeing more specialty pharmacies pop up. When I talk a little bit more about pharmacies, we'll talk a little bit about digital pharmacies or digital online pharmacies, but there's a shift to more specialty pharmacies supporting these services. In many instances, these drugs require patient education and adherence monitoring. So we're seeing more niche specialty players. We know there's an impact on formularies. Rebates are probably one of the most obvious areas of concern and of the revenue stream. As we're seeing more of these high-cost drugs, we're seeing impacts on formulary decisions where some drugs stay on the formulary and others don't. Regulatory, I talked about it as a whole. We're seeing more regulation on the high-cost drugs because these are the drugs that patients are having a hard time affording. And again, we're seeing more accessibility and affordability as part of regulation. And then finally, pharma's playing their role. There are many patient assistance programs. It's unclear if these are sustainable. These drugs are often expensive, but so it raises questions about the pharma's ability to kind of sustain these programs. So why does it matter? Why are ultra high cost drugs changing the PBM landscape? The bottom line is these drugs are having a detrimental impact on budgets. It's not sustainable. There are discussions about these drugs actually bankrupting Medicare, as an example. Employers are having to make difficult decisions about how they will use their financial capital. So again, I ask, what is your role? Is your organization making the right choices around coverage and vendor partners? Do you have visibility to the patient cost and experience? Are you doing your own due diligence, or are you relying on others? And are your members healthier as a result, or are you able to measure that improvement? The third area is the tech-enabled direct-to-consumer movement. This one actually overwhelmed me in my research because I didn't realize there were so many things coming to market. It shouldn't surprise me, but there are a ton, and I hope to kind of wear you out quickly so I can come back and say, well, that was my point. The reality is there are a ton of direct-to-consumer apps and companies out there. And so we all in the room have a responsibility. I'll talk through a little bit of that. As some examples, telehealth, it hit its peak during COVID, but even today, 22% of patients are still getting their care via telehealth. So it is a common way for people to receive their care. Online digital pharmacies, I told you platforms such as GoodRx or PillPack they're available online. They're just two examples of many. They oftentimes have lower prices than your traditional brick and mortar pharmacies, and they may include other opportunities for like medication management or delivery. While the number of direct-to-consumer online pharmacies increases, Walgreens and CVS have closed more than 1,000 stores, and Rite Aid went bankrupt. And at the same time, we're seeing some direct-to-consumer straight from pharma manufacturers. Pfizer and Eli Lilly, as examples, have created direct-to-consumer websites through telehealth and through digital pharmacies for select drugs in migraine, obesity, flu, diabetes, and other categories. They will find their members or their patients through social media and through ads, and they'll direct the people to find them. As I continue to do some research on the types of companies that are direct to consumer, the list went on. You have health and wellness subscriptions like Care of or Hims and Hers, where you can get vitamins and direct to your home medications. You can get at-home testing kits for genetic testings, for hormone levels, for food sensitivities from 23andMe or Everlywell. You can get wearable. How many people in the room have a Fitbit or an Apple Watch or something similar, right? Tons of data from these. People are still listening. Thank you for raising your hand. So wearable health, again, the consumers are being inundated, right? Then there's mental health, and I'm thinking as I'm researching this, man, I need to call on BetterHelp and Talkspace just to kind of talk through all these different things that are coming my way. So this is live therapists for online counseling. Chronic disease management, Livongo, WellDoc, VertaHealth are examples. They're actually helping to manage diabetes patients or cardiovascular patients. Direct-to-consumer genetic testing, Ancestry DNA helps me to know what I'm predisposed to. If that's not scary enough, going to the doctor and then being told, well, here's what could happen in your future. Then you have personalized nutrition. NutriBullet Balance, hadn't heard of them. Plate Joy, they're offering personalized meal planning and nutrition advice. And then the last one is fitness and wellness. How many people in the room have a Peloton, or maybe you ride one on the gym? Somebody over here, I can't see that through the light. Again, inundated. These consumers are being inundated with all these different ways they could be managing their health or learning about their bodies or their history. And so I mention them and I read through them purposely to say, again, what's your role? Why does it matter? Patients are being targeted at a rate greater than ever. So is there a responsibility of the people in this room to educate the patient? Is there a responsibility of payers to subsidize some of these programs? And how can you hold these vendors, and how do you hold the patients accountable should you be doing that, right? So new entrants are available. They're creating holistic healthcare management. So you should expect to see more strategic partnerships or outright acquisitions. This is a movement that is in its infancy, despite the fact that it's been going on for a couple of years. Expect more and more of it, causing confusion amongst your patients. The final of the four current events I want to talk about are the continued market consolidation. So I'll start with a few statistics. I've always loved statistics. I'm not a pharmacist. There are forecasted greater than $400 billion in spend in pharmacy benefits in 2024. 400 billion. And there are forecasted greater than 7 billion prescriptions also in 24. Won't come as a surprise to you, the three largest PBMs manage 79% of the US drug claims. They account for 70% of all specialty revenue. And pharmacies owned or affiliated by the top three PBMs control more than 40% of the market. And the six largest PBMs handle 95% of the prescriptions filled in the US. Raise your hand if you've seen Adam Fine's chart on vertical integration. I'm not going to show it. More than half of you. He has created a business through his drug channels of just keeping that updated with all the consolidation. And I know what some of you are thinking. Some of you are thinking, consolidation was from 2019, 2020 into 2022, and we haven't seen a lot, and that's true. There are some recent examples. United bought Change Healthcare. Maybe they regret that today. Joking aside, CVS bought Signify, which was a home health company. They bought Oak Street, which is a provider. They bought Scripps, which was a provider. Amgen bought Horizon Therapeutics. Tenet, which is a health system, bought DaVita, which was a kidney dialysis center. So we are still seeing some of it. More recently, Kaiser Permanente purchased Geisinger's health system in their 10 hospital health systems on the East Coast, so it's continuing. But KPMG M&A actually had put out a survey earlier this year, and it suggested that there will be the majority of the KPMG M&A experts are suggesting that we are at a tipping point beginning in 2025 where we will see considerably more mergers and acquisitions. Private equity actually suggested 70% likelihood of strategic transformational mergers and acquisitions, not just bolt-on. Time will tell if they're right. It's pretty easy to make a prediction if nobody's going to follow up and see. But the reality is mergers and acquisitions will continue to happen. If I were to talk about, well, why did they happen in the past? It's a little bit different than why they're happening now. So I'll go a little bit quickly. But typically when there is a merger or an acquisition, it would be because there's a cost efficiency, right? Leading to economies of scale or lowering operational costs. Or maybe it was market power, gaining increased bargaining power with suppliers or insurers. In some instances, companies may have come together for access to capital. Or maybe they're consolidating allowed for a broader range of services. And certainly, I've said it multiple times, to be able to work through regulatory requirements. But the changing market dynamics are actually changing a lot of that. Companies may still do M&A for the reasons I just mentioned, but we're seeing more on the focus of value-based care. Many of these mergers are driven by a shift towards value-based care, where healthcare providers are incentivized to improve patient outcomes rather than simply increasing the volume. I think we would all agree that could be a good thing, so hopefully that is one of the examples of things that can come. You may also see M&A as a result of integration of services. So companies are looking to integrate those various healthcare delivery, whether it be insurance or pharmacy benefits or clinical services. You're going to see continued horizontal integration amongst these bigger companies. So in conclusion, what's your takeaway? Again, I asked the room, what's your role and how do you influence this? Companies are going to continue to look for ways to maximize their revenue, maximize their margins, and increase their market share. New entrants are going to work to make populations healthier. They want their programs to be stickier, and they want to grow their market share. So we've seen it with health plans and PBMs. We've seen it with health plans and health systems. We've seen it with health plans and PBMs and providers. The mergers and acquisitions will continue. So things to consider. As a payer, do your contracts allow the flexibility of partnership? Consultant, do you have a good understanding of the marketplace? And are you adapting to that evolving landscape? And does your team have the knowledge to do their own evaluations? Are buyers demanding ROI? And how do you hold the patients accountable for their own health? So that was a long time kind of setting up the background. I know I've been showing the same slide for a while, so now I'm going to move forward into, so how do we adapt for the future? And very quickly, I'll mention these four, and then I plan on going to a few minutes of each in my final minutes. So how do they adapt? We have to, retail pharmacists will play a role. Machine learning, artificial intelligence plays a role. We have to prepare for these increasing costs. And then we could talk about unbundling PBM. So I'm going to go into a little bit more details on these. So first, working with pharmacists. So again, a couple more stats. 58% of consumers say they're likely to visit the pharmacy as their first step for non-emergency care. 58% are going to the pharmacist for clinical evaluations, right? 1/3 of the consumers are reporting that convenience is more important than credentials when it comes to non-emergency care. So I don't care if you know what you're doing, I just need you to do it conveniently for me. 1/3 of the people. And then finally, the CDC is actually saying 9.2 million adults are reported not taking medications that were prescribed because of cost, and instead maybe are either not filling them, are skipping doses, or are taking less than prescribed. 9.2 million adults. So we need to the retail pharmacists need to play a different role. How many pharmacists are in the room? A whole bunch of them, probably the most number of hands I've received so far. I better be careful what I say. I want to go back. I reviewed the FTC report earlier, and I just want to highlight just a couple quick things straight out of that FTC report. The Federal Trade Commission, they started their inquiry in 2022. The report actually only came out late last year. Specifically states, a handful of dominant players wield enormous power over the patient's ability to access and afford their prescription drugs, which allows PBMs to significantly influence what drugs are available and what price. Also, PBMs hold substantial influence over independent pharmacies by imposing unfair, arbitrary, and harmful contractual terms that can impact their ability to stay in business and serve their communities. So what are the challenges? Well, clearly I just read some of the challenges PBMs are placing on pharmacies, but the pharmacies themselves have their own challenges they're working through. The pharmacists themselves are often the highest titled in the room. They're playing the role of office manager, of supervisory staff. They're having to manage a budget. They're staying on their feet many hours a day, and they're facing burnout. Instead, we should flip the opportunity for pharmacists to work at the top of their license and recognize that they have multifaceted interactions with patients, and they can actually be influential in meeting that patient's needs. Some studies had shown that social risk factors and addressing upstream causes of health disparities actually leads to better health. No surprise, right? The most prevalent social needs include affordability and health system navigation. Health system navigation is a fancy way of saying our process is too complex and it could be made easier. The pharmacist could play a role in that. So what can be done at the pharmacy? Well, a couple simple things. Let's provide the pharmacists with more time with their patients. Let them actually have conversations about monitoring and adherence and side effects and things that they could be doing differently. Let's educate the pharmacists on physical and mental health struggles, at least common ones. We don't need them all to become physicians, but we already know that 1/3 of the people are going to go to the doctor if it's easy, or I'm sorry, the pharmacist if it's convenient. And so the final thing that can be done for pharmacies is let's provide sufficient staffing. Let's have pharmacy tech staffing or improved workload to staff ratios. So why aren't we doing that? Well, the reality is these things are expensive, and somebody has to pay for it. So again, I ask the payer, are the government, are the health plans, are the employers in the room willing to subsidize pharmacies that can transform the role of the pharmacist and give primary care and education to patients at the point of sale? Is that the right decision? And are the payers in the room willing to change their reimbursement model from low-cost, high-volume reimbursements to one that is focusing on the total cost of care and value-based, patient-centered model? I don't know, it's a good question, and maybe you're thinking about it. Can we flip it around? The role of the consultant. Will the consultants offer a path to measure the value of the pharmacist or the ROI in a care model that will make the patient healthier? Think about the impact a pharmacist can have on an MTM program or a chronic disease management program. Now, consider expanding that beyond those programs. How can we use the pharmacist differently? I asked the consultant team. And finally, what is the role of the PBM? Should the PBM be financially rewarded for managing a network? Should they be offered the opportunity to profit by reimbursing the pharmacies less than they're charging their customers? Should that spread be allowed or disallowed? Should it be required reported if it's allowed? Should the PBM be able to own its own pharmacy, especially knowing the impact it's having on the independents? Ultimately, should the PBM be held accountable to finding a better way to actually improve the health of the patient and lower the cost instead of working on a high-volume model like we do today? So I want to reference back to an old adage of quality over quantity. Payers could demand something different. Consultants can navigate clients differently. And PBMs can change their business model to be more value-based and less volume-based. Technology, right? Every day some company says we're using AI, and then you watch their stock price go up, unless maybe you're NVIDIA yesterday. But AI is here. It's not going away anytime soon, and everybody who talks about it seems to be benefiting from it. So I wanted to just share a few things where AI actually can play a role in healthcare. I'm not an AI expert, but I will share you there are things that can be done with AI. So very quickly, I'll go through a few. The obvious ones are things like automated claims review, where we're quickly analyzing claims or detecting unusual patterns for fraud, waste, and abuse. You can look at data for patient adherence monitoring. So you can see within the data if someone's being not adherent, and you train those algorithms enough times and you'll start to point those things out. It could actually lead to a customized drug formulary. Maybe that's the way of the future. Maybe formularies are no longer about covered drugs and instead a formulary that works for you. I talked a lot about all the genetic tests that are available and all the data that's available. AI can be used for cost optimization. Again, predictive analytics can look at utilization trends. It can look at therapeutic alternatives. So there's a lot of drugs out there. Maybe there are alternates. DUR is a pretty obvious one. We can get a little bit smarter once we have medical diagnosis code and we have a history. We can start doing real-time monitoring to support clinical decisions with AI. I think the obvious ones that we all see today, maybe we're bothered by it, but it's real, is patient engagement. So how many times on that same Apple Watch I referenced earlier are you getting a chatbot or a virtual assistant or a medication reminder? A lot of these are AI-based. They're harmless. Data analysis and reporting is probably our biggest opportunity. There's a ton of data out there. That doesn't come as a surprise to you. Those insights on patient records and clinical outcomes that are identifying trends can help make better decisions. That actually could be a great way to start to lower those costs. And then finally, formulary management. Maybe there's a movement toward a dynamic formulary. Again, dynamic meaning changing. Maybe it's not simply a list. How do we get to evaluate and adjust the formulary based on real-time data? Is the drug effective? Is it safe? Is it working? Can we measure that efficacy? So again, what is the role of the payer? I have only two comments here. One, it's expensive. It is expensive and time-consuming to train these computer algorithms, so keep that in mind. Two, be selective and be purposeful. Use the data ethically, not to replace the clinicians, but to allow the interpretation of different data inputs, medical data, lab data, Fitbit data, or patient sensors is what it's called. Make the patients healthier, deliver smarter, more personalized drug formularies, and help impact the better delivery of care. I think it's our opportunity with technology. So next, I'm going to go a little bit deeper on how do we manage the high-cost drugs. And if I had the silver bullet for this one, I wouldn't be standing here. I would be one of those new entrant startup companies that's in the hallway. This has been on the minds of everybody in the room for a lot of years. The reality is the drug pipeline is heavily weighted on specialty and high-cost gene therapy drugs. Medicare IRA capped out of pocket for Medicare patients at $2,000. That could lead to more adherence or more people taking these drugs. So some solutions to be considered. Again, I don't know if any of these are novel, but hopefully you think a little bit differently after I'm done, right? There's a budget. Maybe businesses and payers need to go back to saying we have a budget and we can only pay for what we can pay for, which might mean buying stop-loss insurance or maybe not covering drugs or classes of drugs. I'm not in a position to tell you what to do. The consultants in the room have that experience, but maybe we're at a point where we may need to make tough decisions with our dollars. Prior authorizations are key, making sure people are on the right drug at the right time for the right reason, and maybe doing step therapies of trying other drugs. But be cautious of who's approving the prior authorizations and what their ulterior motives are. There are companies out there that you can connect to that will help you through the PA process. I'm headed down a path that's going to lead to our final section, but partnering with best-in-class companies who have different mindsets and are creating new alternative business models that aim to lower the cost of care. Maybe focus on a modular PBM as an alternative, right? You can create a biosimilar strategy of promotion. Rather than just saying, here's another biosimilar, it's in my formulary, maybe you actually create a formulary that puts that biosimilar in a place where it can be used and hopefully save some dollars. You can mandate participation in some of those programs that I made. I don't know if that'll be well received, but you can start to build a holistic approach. Chronic care disease management programs are covered with the nutrition plan, physician plan, exercise plan, medication plan. So again, continue to think about that holistic approach when it comes to high-cost drugs. And the last thing I want to talk about as a potential solution to the four current events include unbundling the PBM services. I told you I work for a PBM. I've talked a lot about PBMs today, so I want to define, what do I mean when I say unbundle, or what's a virtual PBM? The reality is we're at an inflection point. The biggest companies are getting bigger. They're putting health plans in a position where they have to either choose to partner with them as a PBM or compete against them behind the scenes. Because in many instances, those same health plans are competing against these health plans, or they're competing against the PBMs who own the health plans or are owned by them. So as the PBM industry continues to consolidate, these large insurers are buying the vertically integrated companies. New digital healthcare companies are entering the market daily. So consider choosing a technology platform that has the flexibility and the philosophy to enable the use of different networks, different mail networks, different clinical solutions, different rebate aggregators. This may be the future of PBM. The reality is the most complicated part of this is the claims adjudication, the benefit administration, and it's the service the largest three PBMs have the least interest in doing. They maximize their revenue off of drug spend and rebates. They're not interested in collecting a per claim fee or a per click fee. So when I say let's unbundle the PBM services, I'm talking about a virtual PBM strategy where a payer replicates some or all of the functions of a PBM using a technology best-in-class healthcare company and coupling it with their own capabilities or alternate vendors. No longer having to buy all full-service PBM from one PBM. And when it's done correctly, it allows control of the benefit, visibility of reporting, flexibility of partners, and aligned incentives, all with the goal of managing the total cost of care. And as a side benefit, you're not competing against your own vendor in the health plan space. So, What does my experience suggest in the health plan world, which eventually trickles down to employers and others? I believe that the health plans want that interoperability. They want the ability to connect with different vendors. I've talked a lot about new entrants into the marketplace and some of the things they can do. They want the ability to change those vendors, and they want control over their business. And so specifically things like integrated formulary tools, clinical edits at the point of prescription. They want a better member engagement experience, and they want a more powerful, interoperable, and scalable technology platform. So should you be considering unbundling? I don't know. But if you should do that, then I would say look for one with experience in the market segments you serve. Align in your partner, in your culture, your vision, and your strategies. Look for data interoperability. Look for API first as an example, or cloud-based, so you get the scalability that you may require. And your partners need to solve for something or complement a service that you may not have. And finally, embrace flexibility and creative design. So, conclusion. What can the future hold? We should expect more state and federal legislation influence. We should expect more direct-to-consumer technology. And again, if you weren't overwhelmed by my notes, continue to read about it. It's not going to stop where it is. There will be more high-cost medications, including GLPs, which will continue to be the drivers of drug trend. And there will continue to be market consolidation. So, solutions. Payers and consultants need to think about and be ready to evaluate what is the role of the pharmacist's primary care? What is the role of technology? Again, with technology, set that expectation about timing and cost and what can actually be done. High-cost claimants, the tsunami of healthcare costs from high-cost specialty payments, holding manufacturers accountable to the new therapies, ultimately with the goal of lowering the total cost of care, will help to protect that affordability and access to these life-saving drugs. Here are my final statements. They represent my opinion as it is based on fact. The reality is the path of the US is not sustainable. We have to find a new approach to revolutionize the way of doing PBM. The US spends more on healthcare than any other country at $11,000 per person annually. Many surveys suggest, despite the high spending, we actually don't come in first in most health outcomes. I didn't have placement, but I know it's not the top and I know it's not the bottom. Some of these metrics include life expectancy, infant mortality, and prevalence of chronic disease, and that shows that the US is not performing well. So our results for these high costs just aren't where we need them to be. And at the end of the day, we have millions of people who are uninsured or underinsured struggling to pay for these drugs. I began this story with the story of start with why. I talked a little bit about my clarity. Hopefully I was relatively clear in my message to you today. Happy to discuss otherwise. I told you a little bit about Abarca's why of finding a better way in healthcare. We believe it starts with prescriptions. And so I asked this audience, are there any honorary Abarcans who will join Abarca and join me in finding a better way in healthcare? Supporting that philosophy of getting to lower cost and supporting that philosophy of helping out patients. And I'll ask you, what does the future hold? Thank you. Those are my prepared notes. I do have a few minutes if you have any questions, but thank you for the opportunity to share.
All right, does anybody have any questions for Jesse before we wrap up this session?
In a future where someone's information is almost as valuable as their own dollars, how are we going to protect it from other PBMs or other institutions that would seek to exploit it in the new age of technology and AI?
That's a fantastic question. I would put it back on you to say, what would you propose? Again, we're seeing regulatory influence. There's a lot of ethics involved here. Will the large PBMs and other data aggregators do the right thing? You're absolutely right. The value of our data has monetary value, in some cases almost priceless.
Any other questions? Okay. Jesse,
thank you.